Oh my God, this is our last episode of season 3.
Mm-hmm.
But maybe not the last episode of the year. Wink, wink.
We have surprises.
We do. But holy shit, this episode was crazy.
Mm-hmm.
Like, just the information coming at us, and also how Dr. Strom and Meagan Watson are just so real.
Yeah. Whenever I find a clinician who just keeps it real and just lays it out,
yeah,
I love that. I mean,
yes.
I do not take that for granted, especially in the neuro world.
Totally. And I in my mind was just blown, and this hit. I didn't even know this hit close to home until I learned this information. Then I went to my doctor. I was like, "Hey, what's this NES stuff?" And I think you were the one to point out. You're just suit up, and NES is something a lot of doctors don't bring up. And
yeah, it definitely felt similar to the suit up conversation when we're like, why are physicians not talking to us about this stuff? This is big stuff that we should probably know. And these two really kept it real, like I said earlier, kept it real with us and just told us, yeah, it's a huge problem. And so let's at least talk about it in this space on the podcast and spread the word. And yeah, we hope you guys enjoy it and you learn something. And yeah, if you feel like it, bring it back to your doctor and just ask them about it.
Yeah, definitely. That's what I did. And I learned a whole lot about my epilepsy. So, okay, before we kick off this last episode of the season, we want to do our fan and fave of the week.
Yes, the fan of the week is Beth. We received an email from her.
Yes.
And yeah,
and it was so sweet. It was
really sweet.
I love this one. Starting my days on the treadmill with Landis and Lexi podcasts. So amazing.
Props to you first.
Honestly, I think that's why I love it, is because I'm like, I can't start a day on the treadmill. That is fantastic. Good for you. And then our fave of the week is one of our OG faves of the week, Temporal Teas. They have just funny merch related to epilepsy. So, of course, we're going to be drawn to that. We have a link to their Etsy shop in the podcast description, but definitely recommend you check them out. They just like to approach epilepsy with a sense of humor, because as we know, it's a pretty solid coping mechanism.
Yes. We'd love to thank our sponsors for getting us through seasons 1, 2, and 3 now.
So amazing.
SK Life and Neurelis. Thank you. We would not have gotten this far without you. You guys believed in us before season 1 was even a thing. So we cannot thank you enough, and we cannot believe that we got this far, and we would not have been able to do it without you guys. So we appreciate you so much. Your family, 100%. We love you.
Yes, I echo everything Lexi just said. Thanks for 2023. Okay, guys, we're going to let you listen to Dr. Strom and Meagan Watson. Here we go. Hey, guys, welcome to What the F. Today, we are so excited to have in studio with us Dr. Laura Strom and Meagan Watson. Hi, guys. Welcome. Thank you for being here. Just a quick bio before we dive in, because we want you guys to do most of the talking, if not all the talking and everything. We've got so many questions. Dr. Laura Strom is a neurologist and epileptologist. She founded the NES clinic, which is a part of the neuro department, a part of University of Colorado Anschutz Medical Center. And she is the medical director and founder there, which is absolutely amazing. Can't wait to get into more of that. And Meagan Watson is the program manager and developmental specialist at the NES clinic in the neuro department of the University of Colorado Anschutz Medical Center. I keep looking at my paper being like, did I get that right? Okay. Well, welcome. We are so happy to have you here. And we're kind of just going to start off with the question our audience probably has, the same one we had, which is what is NES? Let's start there and see where we go.
Well, a lot of people refer to NES as PNES, which P stands for psychogenic. But that is a term that has fallen out of favor because it depicts an etiology that we in fact don't know. So non-epileptic seizures are a manifestation of what looks like a seizure on the outwardly to a clinician. And then when we obtain a scalp EEG, we don't see the typical brain waves that go along with seizure activity. And so we understand it as something that looks like a seizure but is not a seizure. And so we have this silly term for it, non-epileptic, like we're calling something that it's not. There's a move in our field to really redo that, but there's a lot of controversy about what to call these. There's a lot of people calling them functional seizures. People in the UK are calling them dissociative seizures. The word seizure persists because that's the experience of the patient. Something seizes their body and they can't stop it. It's involuntary. And so the lived experience of people who are, having NES are they're having seizures. And so it's been difficult to take that away because that
is the most validating thing I've ever heard.
Yeah.
Just like, thank you.
Oh, you're welcome.
Because there's so many times when you hear, like, well, that's not a seizure and that's not a seizure and that's not a seizure and that's not a seizure. And you're like, okay, well, we're just going to not name it.
Not only that,
not having a name is hard.
It is. It is. If you can't name something, how can you treat it? And there are shocking studies out of Australia looking at the fact that doctors diagnose this and then they don't tell their patients that they have it.
Oh gosh.
They diagnose it, they put it in the chart, and the patient never knows. And so we know this from from our point of view, that patients come to us, and I always say to them, what did your doctor tell you? And they say, well, my doctor told me I don't have anything wrong with me.
What is the reason that doctors have for not disclosing that?
Oh.
That's what I'm very curious about.
Well,
we got some laughter
we're
going
opening
on.
something
I
up
can't wait.
here.
Let's hear. What is it? Give us the dirt.
I wrote, on the basis of interacting with a couple of young medical students who were naive to what was happening and overheard doctors saying stigmatizing, unfortunate things about their patients, actually sometimes right in front of the patient. And I started asking patients, well, what did your doctor tell you? Like I said. And what I really have come to understand is that most physicians are completely uncomfortable delivering this diagnosis because they think they're telling somebody that it's all in their head. But I always say to a patient, well, what is in your head? And they don't really get that. I say, well, your brain is in your head. That's where your brain is. And yes, your brain is not functioning correctly. And I give it a biological explanation because we have burgeoning evidence now. It's small, it needs to be repeated. But we know that the patients who have non-epileptic seizures have different wiring. Their signal processing is just simply different than patients who don't have this disorder. And if I had to theorize, and other people have, I knew this at a gut level many years ago, is that these patients are traumatized. And we know that from our data now, that over 95% of our patients are traumatized when we see them. And that's in the non-epileptic seizure literature. It might be a little bit smaller in some of the other kinds of manifestations of functional neurological disorders. But these people are traumatized, and we all know what happens when you're traumatized. Just at the very basic level, if somebody is being hurt, then they're hyper aware, hyper alert, and watching their six all the time. Like, who's going to come up behind me and do something bad to me next? That's not normal. It's a normal function of trying to survive, but it's not normal reaction to have a sound in the other room and then jump 6 feet because you think it might be somebody coming after you. And so their brains are just wired differently. And that's the way I kind of look at this. But I have to say that the lived experience of somebody with non-epileptic seizures is that their body is doing something that they can't control. And it is debilitating.
What does that look like? We know, like terms like tonic-clonic seizures, partial complex seizures, for NES, like, are those still, like, is it like kind of like, oh no, it's all the same umbrella, but we've got this is just a tonic-clonic NES but not showing up, or this is a partial complex, or I mean, there's so many seizure names.
And they manifest in different ways.
Yeah.
Or just one.
Yeah.
And what's in a name, right?
Oh God, right? Thank you.
Yeah, no kidding.
Yeah.
Especially when we can't agree on it. And
they change all the time.
Right.
I'm like, I think I'm saying the wrong one. Like,
yeah.
And people say that to me all the time. They're like, I don't know if this is the right name. And I'm like, I don't care. Yeah.
Exactly. So the quick answer to your question is that non-epileptic seizure can look just like an epileptic seizure. It's very hard to guess. You could flip a coin and probably do as well. If it's an epileptic seizure, we're better at that. We can point those out pretty consistently. But we have to do the testing to make sure that, something is non-epileptic, because it looks like any of those things that you described, tonic, clonic. But usually the movements are asynchronous and eyes are forcibly closed. There's some clues, but they're not reliable clues. So, do you want me to guess with your healthcare? No. Right?
No.
I feel like that's all we do though with epilepsy.
Well, I mean, it's
we're like, we're gonna guess that this medication works, and we don't know.
So frustrating.
10 medications later, I'm like, I've been guessed at.
Well,
before,
I'll just say that the truth of that is that if we could go back and do this over, we would not call it epilepsy. We would call it the epilepsies, because epilepsy is not just one thing. It's a lot of different things. It's channelopathy. It's, lesions in the brain. It's all kinds of things. And you're right. You make a clinical judgment about the kind of epilepsy that the person has. And then you pick the right drug for that problem. Drugs don't work for non-epileptic seizures. Epilepsy drugs don't work.
That really hit.
Yeah. Do a lot of people, get mistreated and they have non-epileptic seizures and they're put on the drugs, and then years later they find out, I didn't have to do that.
Well, we can talk to Megan about that, because she has really delved into healthcare utilization and what comes of this.
I mean, the short answer to that question is the international average delay to diagnosis for non-epileptic seizure patients is 7 to 8 years. So they go about 7 years having seizures, being tested on different drugs. Unfortunately, we've had patients have VNSs. We've had some patients have DBSs, which is kind of for movement, but, inappropriately placed. I mean, it happens all the time. And to go full circle, right, it's where Dr. Strom started, which is it's just not taught. It sits right where neurology meets psychiatry. There's a lack of clinical ownership for the diagnosis overall, doesn't make it into medical textbooks. And so, I think it's something that I do as a non-clinician, helping patients understand, is that clinicians are just as kind of lost about this as patients are a lot of the time. Doesn't mean they shouldn't go and figure it out, right? But there's that fear and stigmatization around it, because it kind of is a behavioral health disorder with a physical manifestation. So it's scary for physicians, a neurologist to say there's nothing here, go see a psychiatrist, but then that psychiatrist says you're flopping on my floor, right? That's physical, that's not mine, go see the neurologist. So a lot of confusion, and we're working hard to dig through all of that, but we're still at the beginning phases.
Mm-hmm.
So can a patient have epileptic and non-epileptic seizures?
Anywhere from 10 to 15% of the time.
Okay.
Yeah.
Wow. My journey, there were so many times where I'd be like, I feel like this weird thing happened. And in retrospect, and with talking to my doctor and neuropsychologist, and it was like, yeah, those were NES. Those are NES, and I was like, oh, so I can have both. And they're like, yeah. And I was like, oh, really wish I had known this at the time, because so many times, we doubt ourselves, we get doubted by doctors. And it's not to say anything against doctors. It's like a lot of times doctors are working with data and, going off of that. But I just don't want anyone listening to feel invalidated, or like, oh my God, I don't have epilepsy. I only have this. And it's not necessarily one or the other. It could be both. It could be just NES. It could be just epileptic, but it is possible for both. But that was like a huge gleaning moment for me, and truly only happened recently when I looked at your guys' website and I was like, wait, this sounds very familiar. And I went back and I was like, question. And so I was also possibly, I haven't dug too deep into it yet, but I'm like, why didn't you tell me? Why do
Sometimes
I
you have to like
ask?
really, it feels like you're pulling the information out of them.
Right.
You're not only the patient, but you have to be like an extreme advocate and then also part doctor at the same time, doing your own research. Hopefully that it will change. But I mean, what do you think will have to happen to have that kind of environment change to where we can just walk into, a neuro appointment and have just the straight up answers be told and just, not feel like they're keeping stuff from us?
That's a great question. That is such a great question. And I think the answer is a little bit complicated. But, when I went to medical school, I wanted to be a psychiatrist. And my father's reaction was, oh, I thought you were going to be a real doctor.
Oh, whoa.
Yeah. So I just want to start there because there is this implicit stigma around psychiatric disease. There's a lot of stigma just left over from last century about psychiatry in general. And so if this requires a psychiatric approach, and we have studies exciting studies that actually show that the connections between the brain's regions change with cognitive behavioral treatment. Like if your brain is used to thinking one thing and having a seizure as a result of that trigger, then it's wired a certain way. And if you can use a therapy that lets you think about that differently, then you can build a pathway in another part of the brain and actually have your body respond differently. And this is being shown with functional imaging studies. Again, they're very small studies. They need to be repeated, but they are exciting that we actually can use this kind of treatment to fix people with this problem. And I think that, the stigma of psychiatry and behavioral health, I think that not only the lack of education, actually a hidden curriculum that is really further stigmatizing to patients and denigrating them, as I think, Lexi, you were mentioning, you have to pull something out of a doctor. And Landis, you mentioned also, like, what do we call it? Back in the bad old days, they called them pseudo seizures, which means
they still do.
I know.
I've heard that term.
They still do. It's all the time. And I mean, to go along with what Dr. Strom is saying, it's just a fundamental need to stop separating the mind and the brain. And so to think that we're, prescribing pharmaceuticals for psychiatric problems, but then we're unwilling to potentially put neurology and psychiatry together, it doesn't jive. It doesn't make sense, right?
Totally. Well, that just like hit so home when you said I think I'm going to quote you, but the need to like separate the mind and the brain. Yeah. I was like, whoa, like I've never thought about that. And it's so true. The mind and the brain. And it's like, that happens all the time, right? Like if you're explaining to your neurologist, like, well, I am experiencing depression, but like, oh, well, that's just, that's not my department. That's another department,
that gets pushed off somewhere else.
Yeah. And I always say the best thing that I ever did was start seeing a neuropsychologist who specializes in epilepsy and as well as NES, which I didn't know until recently because I didn't know what NES was. But I just think like, just connecting and making that connection in a medical sphere between the mind and the brain. Oh my God, that just like warms my heart. But so Dr. Strom, you mentioned cognitive behavioral therapy. Can we just take a minute to talk about what that looks like, what that is? And I don't know if this is more Megan's department or Dr. Strom's department, but like what, just for, our listeners, into what that looks like.
Well, cognitive behavioral therapy was the brainchild of a UPenn psychologist.
Because for your dad, you became a real doctor, right?
Well, I mean, I wanted to reverse that dichotomy. I was interested in the brain, but I found out that psychiatrists weren't so interested in the actual neurological brain. And so it just was more natural for me to be a neurologist.
But look how cool it is, like this full circle thing you're doing. Warms my heart.
So anyway, cognitive behavioral therapy is, the gist of it is that you confront a cognitive distortion. Like, I'm a bad person because, I don't know, my father wanted me to be a real doctor. And so I wasn't smart enough to be a real doctor. And that's the cognitive distortion. And my father doesn't respect me. And then I say, no, is that really true? No, that's not true, because, he helped me with my calculus homework, and he knows I have a good mind, and he just has some ideas about psychiatry that are wrong. And so then I can say to myself, no, I'm a good person. And so I'm rearranging my thought process, which may have been, founded in old tapes, because my father was a very critical person. He was an electrical engineer, and he always wanted me to be X, Y, and Z. And why can't you just be a programmer, And so I got criticized. And so I got used to this idea that, oh, maybe he's right. Maybe I'm not doing the right thing here. So a cognitive behavioral approach would be to look at that distortion, really fact find about it, figure out how it makes you feel, figure out what kind of reaction you're having to it, and then change that reaction. Like, this is not true, and I don't have to feel like I'm stupid, and I can be a psychiatrist, and that's perfectly fine. And Dad will get used to it. What the field is going in a different direction now, because of this dichotomy that Megan mentioned, separating the mind and the brain. I mean, they're not separable. They really aren't. And there are a lot of folks who want to call cognitive behavioral therapy neurobehavioral therapy, so that it really brings it back to the place where we understand that we're changing the network, we're changing the wiring in the brain. And so that's kind of the neurologist's perspective. If you asked a psychiatrist that question, you'd get a lot of other stuff, I'm sure.
Well, I like this answer.
Yeah, no kidding.
And I think it's important, too, to what Dr. Strom is saying, CBT, often when we are approached by patients and we say, hey, we use primarily CBT, they say, well, why am I doing that again? I've done it 10,000 times for my potential depression that's comorbid, my anxiety that's comorbid, and so CBT can be used to target different disorders. There are techniques to use. There's a formulation to go by, but it can be very unique to the patient. And I think that's something that we run into with this disorder, which is really difficult, is because each patient is very unique based on potentially what's happened, obviously, in their life. The biopsychosocial approach is what's used generally for all functional neurological disorders, which is what non-epileptic seizures are a symptom of. But it makes it tricky, right? Because what works for one patient might not work for another, or a combination of things may work for one patient versus another. So it makes advancing the field pretty difficult because of how we have to research it, right? What actually matters to the patient versus what matters to the clinician versus what matters to the funder who's funding the research to do, the actual treatment. So it can get really messy really quick.
I'm so curious about what a patient's experience looks like in your clinic, so they come to your clinic, and then how do they get there? And then what does that experience look like?
Yeah. Is this right after being diagnosed? Is this, like you mentioned, 7 to 8 years later?
Yeah. And are they just like, I think this is me, or does a doctor have to get you there? Or I'm just so many questions.
Well, the preferred route is to make sure we're doing the right thing, because a person who's waited 7 years to get the right diagnosis doesn't need another wrong diagnosis. And I mean, that's how I feel. And the International League Against Epilepsy has developed a white paper that really talks about what do you need to diagnose a person. Well, if you want a gold standard, you need an EEG that captures the seizure and has a video so that you can see the seizure, you can see it on the EEG, which shows up as background noise and, regular brain waves, not epileptic brain waves. And then you need, anyone who's having seizures deserves to have some imaging to make sure there isn't something in their brain that, all kinds of behavior can be caused by brain lesions. And, you don't want to miss something like that. Yeah. So we want patients to have a proper diagnosis, but we don't want to delay diagnosis. Like I said, the lived experience is that this is something that's out of control and debilitating for the patient, and they may have waited that long, and they may not have ever been able to capture an EEG seizure with a video. Yeah. So what we do is we will take a normal EEG, interictal, especially if there's several of them, because that assures us that the brain has normal brain waves. And then we also will accept a video that captures a typical event that I can look at and say, that's not an epileptic seizure. If I don't feel comfortable, if the person's just sitting there dissociated, I can't say anything about that. I wouldn't expect to see it on an EEG in particular, if it had been captured, and there's no output that helps me understand what the patient's experiencing. So we have to be really careful. That's a probable diagnosis if we can get the normal interictal or the, no seizure captured EEG, and then a video that's convincingly non-epileptic. And then we can see those patients as well. They get referred, I think Meagan can speak to this because she manages it the best.
Yeah, I think the clinical piece is so important, but to get to the emotional piece of it, Landis, is they're mad, they're pissed, rightfully so, and they're often told to do many things, take many different drugs. Many of them, unfortunately, have gone through days of inpatient ICU care. It's not uncommon for us to have patients who have been flight for life and intubated and these types of things because, granted, the clinician might be doing the right thing at the time, right? They're supposed to respond to a seizure as if it is a damaging emergency to the brain. But because of that miseducation, a lot of non-epileptic seizure patients get abused and suffer what's called iatrogenic harm because we don't know what's going on, especially in those kind of emergent acute cases.
Wow, that is so intense.
Mm-hmm.
So I guess my question is, just because I feel like you two are just like spitting the truth, and I just have been dying to ask this. I know, right? How reliable are EEGs? Because that is something that, like, and Lexi knows this is like my thing I hate. I've had 5 inpatient, 5 outpatient. I caught one. I did not know how lucky I was to catch that one. It was the second epileptic seizure I'd ever had. And the doctor came in. He was like, yes, we caught a seizure. And I was like, I am going to murder you, because I did not understand. Like, I'm postictal and it's immediately after, and I didn't understand what a gem we had just caught until later in, my epilepsy experience. But I don't know. My question to you, how reliable are EEGs?
There's a couple of different kinds of reliability that we look at. One is inter-rater reliability. Like if I read the EEG and I say this is abnormal, is, the next doctor going to read it and say the same thing? So that reliability in the hands of a non-epileptologist, and I'm tooting my own horn, but we're trained and we do EEG, and in our hands, the reliability is pretty high. Not as high as we'd like it to be. But if you've had an EEG and it's been overread, in other words, somebody said, oh, there's this thing. Well, I'll just give an example. It's something called phantom spike and wave. And somebody says, oh, this person has epilepsy. And another epileptologist would look at it and say, well, that's a normal variant. So we're not going to call that epilepsy. We're going to call, we're going to get another EEG and verify that this is going on with the patient. So there's some mix-ups that happen with what we call normal variants on an EEG, and they get overread by people who aren't expert in reading EEG. So that's one problem. And then the other problem is that you can have epilepsy, and you, as you have just pointed out, Landis, have many, many, many hours of EEG that look normal, and then suddenly you have a seizure that comes to the surface enough that it's actually recorded, and somebody says, oh, well, there's a seizure. So the sensitivity is also a problem. In other words, if you don't capture the event, there's a lot of EEG that looks really, really normal, and you can't say that person doesn't have epilepsy. So the more EEG you get, the better. That's expensive, so that's not good. But
Right.
You have to get, like you said, you have to get really lucky and catch that gem, and then not have a doctor go in, jumping up and down, yaying because you have an epileptic seizure, which,
I still hate that guy. I have no idea who it was, but I'm like, fuck you.
I was the one yaying after my first one, and the nurses came in there like, why are you happy? You're supposed to be like crying and post-it. I was like, no, been waiting for 5 years for this.
Yeah.
No.
Yeah.
Yeah.
It was like Christmas morning.
Yep.
The kind of
Best
really messed up.
Christmas present.
I do
Oh,
want
I was
to
happy
I do
for
want to
him.
really emphasize something that Meagan said. I reviewed, somebody sent me a video on my phone and they thought it was a non-epileptic seizure, and I wrote back to the doctor, that's an epileptic seizure. I mean, I had classic features, and so you don't want to misdiagnose somebody and either in either realm. And the reason the question is important about how accurate EEGs are is I have to go to bed at night and feel like I have given the right diagnosis to the patient. So I need assurance that not only the EEG was read correctly, but that I overread it and I agree with it, and that it actually had enough on it that I would have expected it to show something if it were an epileptic seizure. And this is a common mistake that doctors will, make. They'll send me a patient and the patient hasn't done enough in their seizure to really expect any sort of change on the EEG. Like if my seizure is this, and that's silly. It's a silly example. I'm moving my finger.
No, that's what I do during my seizures.
Yeah, what part? Yeah,
you hit me.
What part of the brain?
I feel seen.
Right.
Sorry.
What part of the brain is gonna, and what portion of the brain is actually gonna register that activity on an EEG? Not very much. Not enough for me to see it on the EEG. I think I'd need, a whole arm movement. Or I'd need this hand movement to be some kind of automatism that reflects an alteration of consciousness. So if I get that and I know the patient is not responding, then I would expect something on the EEG. But if they're just moving their finger, like an aura that some patients have, I don't know that I would see that on the EEG. And then I would misdiagnose them.
And I think what Dr. Strom said earlier is critical, is she as the physician also has to go to bed at night. And I think it's something that we forget, or, when we get caught up in a lot of this mistreatment that happens, fingers get pointed, and rightly so. Patients are upset and they have been mistreated. But I think the easiest answer for a neurologist or an epileptologist when they are faced with a patient who they are unsure is to put them on a medication, is to protect the brain, because even if it is, incorrect, well, at least we're not going to hurt the brain. At least, the patient is safe. And with non-epileptic seizures, they're not inherently dangerous to the brain unless you have a secondary injury. So that I just want to point that out, because I think it's important that at least, we're discussing that physicians are trying to do the right thing, because at the bottom, at the end of the day, they're not taught about this disorder. So at least they're trying to protect the patient. Whether or not that's right or wrong and how long that lasts, blah, 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 is up for debate. But
yeah. And even hearing you guys try to describe this to us, and you did it beautifully, thank you. But I cannot imagine how that is describing that to the patient in the room when you have to say, I didn't get enough of that, EEG or that movement or anything like that. I'm, being a patient, I can totally feel that would be frustrating for both sides, but they probably don't see your, side of the frustration as well.
Mm-hmm.
Well, there's also the frustration that there's no treatment. So even if we do get the right diagnosis right away, one of the only clinics in the whole nation that treats this multidisciplinary and comprehensively. So it's, even if the provider ends up at the correct diagnosis, then they say, I don't have anything for you, which is another complicating factor, right? And really difficult for them as well.
That is the question I'd like to end on, is just like, let's say someone's listening to this right now and they're like, oh my God, this resonates so much with me. Like, what should they do next? Because like, what do you do, especially if they're in an area where this isn't maybe recognized? They're not in Colorado. They're not able to get to you guys. What is the next step in asking their doctor about it?
Well, I think that the studies that have been done show that if you give people the diagnosis, give people resources like FND Hope, and that has shown to really reduce healthcare utilization in this population. So if we just simply tell the patient the diagnosis, I know that sounds ridiculous, but just tell the person what they have, give them the diagnosis, make sure you've got it right, of course, and then give them resources. And we have people coming from all over the nation trying to get into our clinic. It's heartbreaking, because we're not licensed in these other states and literally have to move. And we do not recommend that people disrupt their life like that to come here. It's not good. And there isn't any reason on God's green earth that a doctor can't deliver this diagnosis in a sensitive way. And I'll just say to you, Lexi, I don't really describe anything to my patients. I just listen to them. And if you just listen to a patient
that listens, oh my gosh.
You know, I mean, you've
heart
got to
just
listen. You
melted.
can't,
Yeah.
there's no way that I can help anyone if I just don't listen to them. And these people have been repeatedly not listened to and not heard.
Yeah.
So you've got to listen. You've got to give them resources. You have to be truthful. And if you need more work, you say, I'm here and I'm going to do this. I'll walk with you and I'm going to do this extra work because we want to get this right. Like I said before, we don't want to gamble. We don't want to guess about your health care. We want to be correct about it. And you've waited long enough to get here. So that's what we're going to do.
Yeah.
And I think that what patients should do is be very frank. Like you had said, Lexi, you have to, there was a book written in the 70s called How to Choose and Use Your Doctor. And, you know, that balance, the balance between being an advocate for yourself and marching into an office and say, I Google searched this and you're getting, you know, I mean, it just drives people crazy. There was well, I'm not going to talk about another article, but that one article about with the philosophy of, you know, the perfect patient who comes in carrying their sick body and gives it to the doctor and gives them a list of what's wrong and they don't have any emotional overlay. Well, that person doesn't exist because illness is experienced as devastation. There's grief that goes along with illness. You know, and, you know, even if your teeth hurt, there's grief about that. Like I used to have perfect teeth and now they're not perfect anymore. The body, you know, has a tendency to do the wrong thing sometimes, no matter how hard we try. And so I want to get back to that lived experience thing again. We have to meet these people where they are and we have to guide them. And if we can't give them the service that they need, and Megan is being modest, actually, we are one of only 19, but when you investigate what those treatment facilities actually do for their patients, they basically give them the diagnosis and then they give them resources. So most of them are not actual treatment, and they don't have a treatment paradigm.
Because they may be told that they have conversion disorder from a psychiatrist, but then they may have been told that they have, you know, pseudo seizures from an epileptologist. Those things are all the same and the treatment is the same. And so that's, I think, really important because then when you start Googling and trying to find resources, you have to use potentially different terms in order to find the correct care. So often, like for instance, the standard of care for patients with functional neurological disorder is go to Psychology Today and find a psychiatrist. Well, they don't have FND listed as a diagnosis that they treat. They don't have pseudo seizures. And let me tell you, I hope Psychology Today is listening because I spent 8 months trying to knock down their door saying you need to list this as a diagnosis because people are being told that they need to come to your website. Psychology Today, you didn't get back to me and you blacklisted me. So, and they stopped taking my
We'll be blowing them up.
But, but what's helpful, right, is to help explain to the patient that maybe you need to speak the language of, and it shouldn't be their responsibility. It shouldn't be the patient's responsibility to figure this out. But something that we have found really helpful is can we help them with the communication and how they need to communicate based on the provider that they're looking for. So for somebody like Dr. Strom, an epileptologist, we would want her to know that the patient has non-epileptic seizures. We don't want the patient to walk in the door and say, I have seizures, because then Dr. Strom is going to say, okay, epilepsy, let's go. You know, we need to get EEGs, all this stuff. But then if you go to a psychiatrist and you say, I have seizures, they're probably going to say the same thing, right? You need to go get an EEG. But if you tell them you have conversion disorder, they will know what to do with it. And so there's that. We have to level the playing field when it comes to how we communicate about this disorder, because I think that's where a lot of the unknown happens. And unfortunately, even if you were to call up one of these other clinics, we've tried to do extensive work to make sure that somebody can find us online. But if you were to call, let's say, I won't mention the other institutions, but if you call up one of the other major institutions in the nation that says that they have services for this, when you call that institution, they say, I don't know what you're talking about. I don't have providers who treat functional neurological disorder. We know it. because we're in the field and we're all, doing the same work. But if you go to their website, it doesn't say that. So that's another really tricky point where an organization like FND Hope, or there's a really good website that was created by Dr. John Stone, who's one of the leading clinicians in this field, called neurosymptoms.org, all one word, neurosymptoms. That really helps explain what I'm discussing, the different names, the different presentations, and how to best, advocate for yourself and communicate to different providers. Because if you can't do that, you won't find treatment, right?
And we'll put both of those URLs in the description of the podcast. But I feel like what you just described is like trying to get into a secret club, like knowing the code words and all this stuff. And you're really just trying to get medical care. And
let's just stipulate that any neurologist that's still using the term pseudo seizures is a Neanderthal.
Thank you.
Well, I think with that we're gonna, wrap this up. That was the perfect way to close this out, Dr. Strom. Thank you.
Thanks
you
for the
guys are
opportunity.
absolutely amazing, and I think I would encourage anyone listening who does not have a doctor like Dr. Strom and doesn't have resources like Meagan, go out, find them. This is what you deserve.
Advocate for yourself.
Yes, you
until
deserve
you get the
this
treatment you want.
Yes, 100%. Thank you so much for just like warming our hearts and just like giving us hope.
It's a great opportunity.
FND Hope.
Thank you. Thank you for bringing it. We need to do more of this. A lot more of this.
Absolutely.
So.
Yeah. Okay. Take care.
Well, thank you.
Bye.